All right, we have reached a critical mass here, so we're going to go ahead and get started. My name is Katie Smith-Green. I lead our content here at Current Health. I'd like to just thank you for joining us for today's webinar, the topic of which is interoperability and care at home, integrating data and workflows. Our presenters for today are Shardul Mehta and Ari Markowitz. Shardul is the Senior Vice President of Product here at Current Health, where he oversees the product strategy and roadmap. Prior to joining our team, he led product management at Amwell, where he was responsible for its acute care telehealth platform and telemedicine devices portfolio. Shardul has also co-founded several startups, has served in product leadership roles for the last 20 years, and has spent the last 12 years in the healthcare technology space. Outside work, he enjoys traveling, movies, the theater, and spending time with his family in Northern Virginia, where he lives. Ari is a product manager at Current Health, where he oversees integrations. Prior to joining us, he was a product manager at Mobile Heartbeat and comes from a background in private equity and consulting. Ari's expertise is in data architecture and business intelligence, focusing heavily on the role of data in decision-making and interoperability. Outside of work, he spends his time eating his way through Brooklyn, where he is based. Welcome to both of you. Thank you for joining us for today's session. And with that, I will turn it over to Shardul to walk us through our agenda.
Great. Thanks, Katie. Whoops. Sorry, let me, there we go. There we go. All right, we're back on track. Sorry, a little snafu. Thanks so much, Katie, for that introduction. Ari and I are delighted to be here, and we really appreciate the opportunity to talk to all of you about the importance of interoperability for a care at home program. So in our discussion today, we'll be talking about three things. We'll explore the changing ecosystem of care delivery being moved into the home. We'll talk about why interoperability is essential to successfully delivering care in the home. And we'll examine strategies to integrate data and workflows in designing a care at home program. Now, first, let me just quickly introduce Current Health. Our goal at Current Health is to help our partners design, launch, and scale safe and effective care at home programs. We do this across the entire health space, including community health systems like Baptist Health, to research organizations like Mount Sinai. One of our largest customers is the Defense Health Agency, and we also do work with global pharmaceutical companies on both the commercial and research side. So let's start by talking about a few trends that have been coming together over the last several years. Now, the COVID-19 pandemic was the catalyst for a structural change in healthcare delivery. It helped converge a number of trends, from the development of new technologies to the embrace of digital health tools by consumers to how healthcare organizations approach delivering care for their patients. In particular, it accelerated the adoption of virtual care as a standard and highlighted the benefits of new delivery models like telehealth, remote patient monitoring, and caring for patients in their homes. We started seeing that care is increasingly moving out of the hospital and into patients' homes. For example, we saw that many patients were deferring care and hospitals were suspending elective procedures. Now, this meant that those patients' conditions needed to be monitored, because without monitoring, these patients could become sicker with more severe conditions, which would require emergency care. Hospitals quickly saw the value of hospital at home programs that helped reduce the cost of care while also maintaining high quality delivery of care. At the same time, technology developers and investors immediately responded to these trends with significant funding that was poured into emerging healthcare technologies that would enable virtual care and providing care in the home. And the results are that people have spoken. Patients love it. They much prefer being at home, receiving care in their homes in comfortable surroundings where they're supported and surrounded by their loved ones. And they would continue to use virtual care services in the future. You know, I don't mind sharing with all of you that our team has done a number of ride-alongs with our customers, with their nursing staffs. And we've seen patients grab their arms, emotion welling up in their eyes, thanking them for their service, that it's changed their lives. That's really, really powerful. Now, all of this has meant that there is an even greater need for interoperability than ever before. In these emerging circumstances, in order for clinicians to provide the best care possible, they need the ability to have a holistic view into a patient's health. And this means ensuring they have the right data at their fingertips at the right time, and designing clinical pathways and workflows that are standardized and help drive efficiencies in how they're able to do their jobs. Now, when we talk about interoperability, it's not just about moving data from one system to another. It's actually about the use of standardized clinical pathways and operational workflows to deliver the care. So let's come back to that in a minute. We all know that healthcare organizations have faced a few challenges to achieve the full benefits of interoperability. Disparate data sources, unique technology ecosystems, coordination across multidisciplinary teams and sites, and limited IT resources, to name a few. In 2019, HIMSS completed a study that assessed where healthcare organizations fell across different levels of interoperability. Nearly 75% were considered between the levels of structural and semantic, meaning they had the foundational pieces in place to move data from here to there, and some had the ability to interpret and use individual data elements, but most are still not realizing the full benefits of interoperability. So, how do we overcome these challenges? Well, for starters, we need to see interoperability as a long-term investment to be utilized across clinical areas. And with care moving increasingly into the patient's home, our collective goal, all of us, needs to be to look at the availability of patient and clinical data across systems as core to providing care in the home. Fortunately, there are now a number of standardized interoperability frameworks that provide a common language around content, structure, and context that can not only help accelerate the development of information exchange across systems, but also help maximize the value from the patient record, minimize duplication of work, and actually improve clinical efficiency. Let me turn it over to Ari now. He's going to walk us through a few of those standards.
Thanks, Shardul. As we just recognized the importance of interoperability regarding clinical data in particular, here we can take a look at the exact methods used to transmit that data between platforms. First, it's important to call out that before data can be made useful, it must be first made available and easily understood. The use of technical frameworks like HL7 are essential to the standardization of data across platforms. The main benefit here is federation across platforms to ensure that pulse rate, for example, always describes a patient's pulse rate in the exact same way, even across two disparate systems. Some common frameworks are outlined here to the left, although we've highlighted HL7 and FHIR here as those are the standards we believe are most commonly used, at least for the types of integrations involved in care at home. Diving a touch deeper, we commonly see HL7 used in a direct interface connection type, where messages are transmitted between a health system and a third-party vendor like Current Health, typically over VPN. FHIR is a relatively new standard that is not yet as widely adopted as HL7. However, in our opinion, it's going to quickly become the de facto standard for healthcare interoperability over the next few years. It's already on its way there today. FHIR implementations can be a direct interface, but we typically see this used as part of an API or endpoint, like in the case of Epic and Cerner's FHIR-specific open APIs. CCDA here is used less commonly, but it's important to ensure clinical data is kept up to date across multiple platforms, and you'd use this framework to do that. Once you've aligned to a standard, the next step is to facilitate the implementation of the integration. And so here to the right, we've outlined some of the ways that this data can be communicated between a vendor like Current Health and a health system. We're presenting the options here to the right and highlighting some of the benefits from the perspective of a vendor like ourselves, having gone through the process of selecting these options. The reason we say that is health systems typically set the standards, and vendors like ourselves will adhere to those standards with regard to integration. I'll turn it back over to you, Shardul.
All right, thanks, Ari. Good overview. All right, so the other aspect that we need to look at is clinical pathways and workflows. In fact, as I mentioned earlier, the reality is that interoperability is more about the clinical pathways and workflows than merely the availability and exchange of data. That's really the place to start. So let's talk about that. delivering care successfully in the home requires some reimagining of traditional clinical workflows. How we identify and capture referrals, enroll patients, monitor them, perform interventions, deliver and coordinate care, and then use population level health data to drive scalable long-term outcomes. This requires breaking through the existing silos of care delivery and systems. For example, today, healthcare organizations often have a combination of EHR solutions across their organizations to support inpatient and outpatient care. EHRs are not really designed to readily support care at home programs with the technology, devices, services, and pathways that are required to successfully care for patients in their homes. So it starts by identifying the clinical use cases you want to solve for, and then designing the relevant clinical pathways to deliver that care, and then incorporating the relevant tools, devices, services, and data to deliver care safely in the home. From there, we can then start identifying how we can bring those data assets together in a way that's useful for clinical decision-making. So we look at three main considerations in designing an effective and scalable care at home program. First, the clinical pathways we want to use for a particular disease or clinical condition. In other words, the structured sequence of actions and evidence-based interventions to be carried out by the care team in caring for a patient with a specific clinical condition or diagnosis. Second, the desired outcomes that we want to measure. In other words, how we plan to measure the success of the care at home program itself. And third, the patient and clinical data that's needed, not only at the time of intervention, but throughout the patient's journey through the care at home program. This includes data that is both enabled by and created by the care at home program. So by putting a healthcare organization's clinical pathways at the center, we can help optimize their existing systems and processes and operationalize them to deliver an effective care at home program. Then from a system integration standpoint, there are best practices we look to take advantage of. So I'll hand it back over to Ari to talk us through those and then dive a bit deeper into data requirements and integration options and strategies. Ari?
Thanks again, Shardul. So when we look holistically at all of the integrations we performed to date, the most successful among them are those that revolved around the clinical workflow. And by beginning with the clinical workflow and working to design a technical solution around that, we're able to most effectively drive adoption and most importantly, clinician satisfaction. This allows us to avoid sort of prescribed solutions, for example, where technology would instead seek to drive the workflow. And from an integration perspective, there are three best practices we in particular look to take advantage of. The first of which here is flexibility. We look to implement a solution that's configurable to bridge all aspects of integrations and hopefully work across different health system, IT ecosystems and implementation plans to design them in a way that it's most effective for that health system. We also will then align with the virtual care strategies, objectives, and initiatives of that health system to ensure effectiveness. The second here is comprehensiveness. The integration approach ensures that workflows leverage the EHR alongside other technologies and systems to manage patient care across all levels of acuity and clinical use cases. And the third point here is scalability. We apply clinical knowledge and technical expertise in a consultative approach to design integrations in a way that reduces complexity and factors in things like EHR upgrades and maintenance, for example. I'm sure this is true for many things outside of integration, but integrating with an EHR like Epic or Cerner is very resource intensive. This is true not only for someone like an RPM vendor like Current Health, but also very much the case for health systems. First, the clinical teams will need to outline the desired workflow, then a VPN or general connectivity will need to be established between the two platforms. Then you'll need to identify the data transmission method and frequency we touched on earlier, and so on and so on. What this means is that the health systems will likely need to devote resources to the project to ensure representation from folks like Epic analysts, project managers, clinicians, and others for each piece of the project. While this is beginning to change with more recent advances in integration methods like we at Current Health are just at the cusp of, these integrations are typically best broken out into phases. Here's just an example of how an integration may be implemented over time, broken up into respective phases based on certain objectives, one after the other. Here, let's hone in on some of the components of data acquisition at a high level. Achieving an ecosystem of connected care is dependent on architecting how you bring remote monitoring data into your EHR. Looking at the gaps between the native functionality of an EHR and an RPM ecosystem allows you to apply this to the care at home delivery and create opportunities for integrated services to be provided across at-home services, care coordination for field nurses, biosensor and device integrations, and this also extends into a mixture of peripheral devices as well. So in effect, the RPM vendor should provide the architecture to stand up an ecosystem of care delivery at home that can be plugged into working alongside the EHR to safely deliver care in the home. Narrowing in on the term we've been using heavily throughout this presentation, EHR integration, here we can see a deeper example of the type of information that is actually shared between the two platforms. The important piece to highlight here is the bi-directional nature of the integration. Information must be shared between both systems to ensure that the integration is actually effective. In this relationship, the EHR is always seen as the source of truth. This is true for documentation, the observation of clinical values, alarming, and patient clinical demographics. Although other platforms like remote patient monitoring will collect their own data, the EHR is where that data is actually always meant to live. Therefore, it's the assumed responsibility of platforms that collect data, like ourselves, to transmit it cleanly back to the EHR and to be documented alongside notes, alarms, and other clinical information. In order to do that effectively, however, the EHR must have the ability to interface with third-party platforms like RPM and we can walk through some of the examples we see on the left, starting with admission and enrollment, all the way up to clinical summary to ensure that the clinical demographic information is consistent across both platforms, and even as a mechanism to sort of launch that secondary platform. And here we talk about Smart on Fire as a framework used to sort of provide that interoperability between the platforms. In return, looking to the right-hand side here, the RPM vendors in return will send back things we've already touched on, the patient's vital signs, spot check measurements like the blood pressure, and other sort of patient-reported or collected symptoms coming from the patient. So as we focus here on making use of the huge amount of data that we just touched on and how we're collecting that, the focus then becomes the easy display and aggregation of patient clinical information. So here we'll look at Current Health as an example in the relationship between an RPM vendor and the EHR and how that data is actually distributed between the two platforms. So across these two systems, monitoring of health data and alarms can be through the health system's EHR, Current Health dashboard, or actually both. When communicating with the EHR, the vital signs are communicated as flow sheets. Typically, this is done via HL7 ORU messages, but we also have the ability to support other capabilities depending on the EHR's preference. The unique part about RPM and Current Health in particular is that we capture continuous data. And for continuous data captured by Current Health, the transmissions occur in aggregates. And what that means is that the data is summarized in a 15-minute window rather than sending that data continuously, as you can see here on the right-hand side. For non-continuous data, this includes things like blood pressure, where a patient will take that in the given moment. Each data point that we collect is transmitted from Current Health to the EHR individually. Most importantly, we want to reiterate that within the relationship between the EHR and a platform like Current Health, again, the EHR is always the source of truth. That's why it's incredibly important to ensure that the EHR is always kept in sync with updates from platforms like Current Health. And integration is used wherever possible to keep data between both of those platforms consistent. Reading this slide here from left to right, we can see that this is a visual representation of the continuum of care for a patient. And along the continuum of care, there's a constant interplay of opportunities to drive integration between platforms like Current Health and the EHR. And so outside of the data piece in particular, here we start to think about areas of opportunity. Starting from intake all the way on the left, where the focus is on finding and enrolling the right patients to the care at home program, all the way to the delivery of care in home via services where the focus is on understanding the patient's location, delivering clinical needs, and even potentially care in the home via nurse visits or technical device support needs if needed. Each segment here represents an opportunity across the patient's continuum of care for an integration point across many different areas of interplay between those two platforms. Diving deeper here into just one of the examples we showed in the previous slide, here we'll take a closer look at enrollment. It's important to recognize that there are several different pathways for a patient to be admitted to the care at home program. And from an integration perspective, it's our responsibility to identify and support those pathways so that the admission can be flawless, irrespective of the type. Clinicians, it's important to highlight, are normally at the front of the care at home admission process, and they are the ones that are actually driving these workflows. Different methods are used to identify eligible populations, like best practice advisories within the EHR, potentially even having representation in the emergency department. This could be a physical person, or health systems having their own remote observation units for patients who oversee a variety of patients from outside the actual walls of the hospital. In either case, we'll need to support a variety of points along different patients' continuums of care and provide standardization wherever possible to allow for a seamless integration between platforms. This means extending technology like order forms within the EHR to be available across both inpatient and outpatient units to ensure that it's a single form across those two, and also ensuring that the information collected on enrollment is sufficient and comprehensive enough to cover every possible use case. And so rather than having one order form for a low acuity and one order form for a high acuity, it's about sort of understanding the full complexity of the program and designing for that from the beginning. This is all, again, in an effort to promote standardization. We'll partner with health systems to not only design connected systems for patient data, we'll work alongside them to ensure that care at home programs are successful in identifying and enrolling these patients into the programs as well. And so it's all related. I'll pass it back over to you, Shardul, for some key takeaways.
All right, thanks, Ari. All right, so we covered quite a bit in a short amount of time. So let me try and summarize some of the key takeaways for everyone here today. So first of all, like we talked about, with care moving increasingly into patients' homes, the need for interoperability has become paramount so we can empower our care deliverers with all the information that they need to provide efficient and high quality care to patients in their homes. Interoperability is about more than just data exchange, as we talked about today. It starts with identifying the clinical use cases you want to solve for, designing the relevant clinical pathways that incorporate the relevant tools, devices, and services to deliver the care, and then identifying how we can bring the relevant data assets together in a way that's useful for clinical decision-making. We want to be able to leverage standardized interoperability frameworks for not just data exchange between systems, but to enable information facilitation across healthcare technology ecosystems in a way that's aligned with our virtual care strategies and objectives, and work with partners who can help you get there who are already taking advantage of these standardized interoperability frameworks. We want to follow an integration approach that ensures that workflows leverage the EHR alongside your care at home platform and other systems to manage patient care across all levels of acuity and clinical use cases. And finally, we need to think of interoperability as a long-term investment. With care moving increasingly into the patient's home, we need to look at the availability of patient and clinical data as core to providing care successfully in the home. So thank you all for this opportunity to share our learnings and thoughts on the importance of interoperability and for successful care at home programs. Katie, we'll hand it back over to you and happy to take any questions that people may have.
Yeah, wonderful. Thank you to both of you. That was great. We do have a few questions. To start us off here, what's the difference or what is different about integrating a hospital at home type program versus something more like a chronic care? What's something to keep in mind?
Yeah, I'm happy to start off, and then Ari can jump in certainly with his perspective. Fundamentally, like I don't think there's any material differences from an interoperability standpoint. I mean, obviously, what it really, like we've been talking about throughout this presentation, there's a lot to consider in terms of the program aspects itself, the patient populations you're targeting, and as a result, the specific clinical pathways, right, that you're going to engage in, how those workflows are going to work. So there's definitely elements there. There's certainly some considerations with regard to, are you doing continuous monitoring versus, non-continuous or intermittent monitoring? And I know Ari touched upon that a little bit earlier in the presentation. So there may be some aspects there. So it's really more about the program design is where is the place to start, which is kind of the message we've been saying throughout this presentation. And then from there, we can talk about, okay, what are the different data pieces that we need to kind of move back and forth and make available to the clinician. And then at that point is where we get back to, let's make sure we're leveraging the right set of standardized frameworks for those integration methods. And I already talked about HL7, talked about FHIR. That kind of becomes the same or similar considerations regardless of whether you're doing lower acuity or higher acuity. I don't know, Ari, do you have an additional perspective on that you want to add?
The only thing I might add is, outside of the walls or the differentiation between hospital, home, and chronic care in particular, we've typically seen health systems start with, for example, a high acuity population. That population might transition to a low acuity over time as they sort of improve, and then potentially they might, escalate back to a high acuity if their condition worsens. So it's always that interplay of between high acuity and back and forth, and sort of hoping to transition everyone from high to a lower acuity state.
Yeah, that's a great point. All right, we got another one here. Would you recommend building out full EHR integration before launching a care at home program, or going ahead and launching that in a limited capacity and then working to identify the priorities for your program?
I can start tackling that one. So my first recommendation is absolutely begin with the program as much as possible from a development perspective without starting integration right away. Any learnings that you can get from applying a care at home program can be applied when time comes to do the integration. So some of the things we touched on earlier about how resource intensive and how complicated the integration might be, all of that is aided by the fact of having some experience or clinical workflow experience and having to sort of the ability to work through the kinks before you begin that process. It might not be a huge amount of time between the pilot and when you begin integration because of course, all the importance we touched on here about EHR integration, but definitely worth getting started and then transitioning over to an integration from there is my perspective.
That makes sense. Shardul, anything to add on that one?
No, I think Ari really covered it very, very well.
Perfect. All right. And finally, we have a rather hard-hitting one. How can care at home programs be sustained financially on the current reimbursements we're seeing for Medicare and Medicaid for monitoring alone? Although the benefit to our patients for monitoring is great, financial profitability has not been so great. Oof, tough question here.
That's a tough one to ask the product guys.
I know, really.
I can give a first stab, but Madison, I think that's who asked the question. I'll highlight the fact that I'm less experienced, obviously, in this area, only the fact that I've worked hand in hand with my partners here at Current Health on this front. So I'll just go a couple fronts here. So the first piece is monitoring alone. So monitoring alone offers opportunities for a couple of billing opportunities. The first of which, and this is what we're working with health systems on right now, are the CMS codes 9953 and 9954. So those codes in particular allow you to bill for specifically the monitoring pieces alone. And I think what it is, and I might be misspeaking, but 16 days of monitoring over a 30-day rolling window. And so just for monitoring that period of time, you can bill for that. Second to that, it's 20 minutes of time spent on a patient, I think, over that same potential window, that 30-day window. There are certain ones that you can continue to bill for every 30 days, and there are certain ones you can bill for once for that patient being monitored. The care at home in general, and when we think about sort of sustained financial ability and where it makes sense, is not just in monitoring, at least in my opinion. When we think about the programs that we implement, it's not just delivering, devices and then moving on. The purpose of our integration work and our sort of work with health systems across the country is in sort of a multi-pronged, I would argue, approach. So one of those prongs is in reducing readmissions. And so when we think about the transition to value-based care and our work to sort of prove that we can, keep patients out of the hospital for longer or reduce their readmission rate, in any number of different ways, that's an opportunity. Second to that, it's also keeping patients out of the hospital when they might not need to be there, and sort of that frees up beds and offers an opportunity for beds to be used for other purposes in a time where COVID is escalating. And other examples, those beds become extremely valuable for the hospital to do other things like special surgeries or opportunities where they make more in terms of revenue with regard to patients. And there's a million other things to touch on, but I think the important thing to highlight, and maybe others can talk to this, but there are way smarter people than myself on this front. But I think the short answer is it's a holistic approach to care at home. It's not just RPM. And I think that's one of the core differences of current health is we're transitioning away and we're not really just RPM. It's more care at home and the infrastructure and everything behind that.
Yeah, absolutely. So much of this topic depends on the type of program and the patient populations and what the alternative to that care is, right? Obviously, under the hospital at home waiver for those programs, we're still seeing that payment parity. We don't know where that's going to go in the future. But I will just venture here that this is obviously a very important and very complex topic that we are really working cross-functionally on internally to create some models and guidance and frameworks that will help programs kind of better plan for this aspect of success and plan for what to expect there as they attempt to launch and scale these programs. All right, Shardul, you want to take us to our final slide here as I take us out. Wanted to just quickly plug our next event will be on May 25th. We will be tackling the topic of health equity and care at home, which I'm really excited about. We'll be joined by Tracy Baker, who leads our clinical operations and implementation, is on the ground a lot with our clients. So she's got some wonderful stories and examples to share. And then Jessie Lever-Taylor, who is on our clinical research team as a clinical research manager there. So I'm excited to dig into this topic and talk about the opportunities and challenges for care at home in the topic of health equity. Watch your inbox for a recording of this session as well as the slides. You're welcome to share those with whoever might enjoy them. Thank you so much for your time today. We hope to see you next time and have a good one.